Welcome to this explainer. Right now, we're diving straight into the absolute high-stakes, adrenaline-pumping first 10 minutes of an emergency department resuscitation. When a patient rolls in with suspected acute coronary syndrome, that clock is ticking loudly. Let's break down exactly how you need to navigate these critical make-or-break moments.
Okay, let's put you right in the resuscitation bay. Picture this. A 58-year-old guy walks into your ED, clutching his chest. He's profusely sweaty and he's pale. You literally have one question to answer. What do you do first? This is a classic presentation to test your clinical reflexes, sure, but it's also a great chance to update your protocols based on the absolute latest evidence. We're going to treat this like a real ED resuscitation, so let's get that clock started.
Here's our exact chronological ED action plan. First, the door assessment, then the 10-minute ECG challenge, followed by monitor, IV, and aspirin. After that, targeted symptom control, STEMI versus NSTEACS, and we'll wrap up with a final ED checklist.
Section 1. The door assessment. The clock starts now.
The exact second this patient arrives, your first task is a rapid-fire assessment. You've got to secure responsiveness and those ABCs, airway, breathing, and circulation. Then, grab a brief targeted history. Are they showing signs of systemic hypoperfusion? Like, are they hypotensive or is their skin cool and ashen? Check for signs of heart failure too, like jugular venous distension or new pulmonary crackles. You need to identify these things instantly. Now, premature diagnostic closure here, it's incredibly dangerous. Tons of life-threatening conditions mimic ACS, so you must actively hunt for the abrupt, tearing pain or asymmetric pulses of an acute aortic dissection. You've also got to consider a PE, or a tension pneumothorax. Think about it. If you mistakenly give antiplatelets or thrombolytics to a dissection patient, that could literally be fatal. Section 2. The 10-minute ECG challenge. This is your primary diagnostic tool.
You have a maximum of 10 minutes. From the exact second the patient hits the door, a 12-lead resting ECG must be obtained and shown to an attending. 10 minutes, no excuses. And remember, this applies to anyone with possible ischemia, including older adults or diabetics who might present with atypical symptoms like sudden weakness or unexplained dyspnea.
When you finally look at that ECG, you are hunting for immediate ST elevation or a high-risk equivalent. We're talking a newly identified left bundle branch block, a posterior wall STEMI pattern, or maybe a De Winter sign. If you spot any of these, you found your culprit. Immediate reperfusion is required. But what happens if that first ECG looks completely normal?
This is a major clinical pitfall. An initial ECG that fails to show ischemia absolutely does not rule out ACS. If that first trace is non-diagnostic, but your clinical gut suspicion is high, you must repeat that 12 lead every 15 to 30 minutes. You have to actively hunt for evolving ischemia, because honestly, hyperacute T waves might be your only early warning sign.
Section 3. Monitor, IV, and aspirin. Establishing the foundation.
So, with your ECG in hand, or while it's being acquired, you've got to simultaneously lock in the basics. Make sure the patient is attached to a continuous cardiac monitor with pulse ox and frequent blood pressure checks. Remember, arrhythmias are caught by the monitor, not your stethoscope. At the same time, secure IV access, draw blood for high-sensitivity troponins, and prep your very first major medication.
And that medication is aspirin. Unless there's a compelling contraindication, like that suspected aortic dissection we mentioned, or a severe anaphylactic allergy, every single suspected ACS patient immediately gets 162 to 325 milligrams of aspirin, and they need to chew and swallow it. Despite its massive, well-proven benefit, aspirin actually still remains underutilized, so do not forget it.
Section 4. Targeted symptom control. It's time to break the MONA myth.
We seriously need to rethink the outdated MONA protocol. Morphine, oxygen, nitroglycerin, and aspirin. First up, oxygen. Do not just automatically reach for the mask. Routine oxygen in normoxic patients has zero demonstrated benefit. And get this, it can actually cause direct coronary vasoconstriction. Only give supplemental oxygen if the patient's saturation drops below 90%.
Next up in symptom control, your patient is still having chest discomfort. But before you automatically hand them 0.3 to 0.4 milligrams of sublingual nitroglycerin, you have to ask yourself a critical question. In this specific patient, is nitroglycerin safe or unsafe?
Well, nitroglycerin is highly unsafe if your patient has an inferior MI with suspected right ventricular involvement. In RV infarcts, these patients rely entirely on preload, so nitrates can cause catastrophic hypotension. It's also an absolute contraindication in severe aortic stenosis, marked bradycardia, or recent use of PDE5 inhibitors like sildenafil. If none of these red flags are waving, then you're good to proceed.
Okay, what about morphine, the M in MONA? Just hold off. It really should not be given routinely. While it does reduce sympathetic stimulation, recent data, like the CRUSADE initiative, suggests it might actually interfere with antiplatelet drugs like ticagrelor. That leads to a higher adjusted risk of death in non-ST elevation ACS. So, reserve morphine strictly for severe refractory pain.
Section 5. STEMI versus NSTEACS. The fork in the road.
With the patient stabilized, your ECG and biomarkers are going to dictate your definitive management. If that ECG shows a STEMI, you activate the PCI team immediately. Do not wait around for troponin results to come back. Reperfusion absolutely cannot be delayed. However, if you're dealing with a non-ST elevation ACS, the management requires a tailored approach. We're talking antiplatelets, anticoagulation, and deciding between an invasive or conservative strategy based on the patient's risk profile.
Section 6, Final ED Checklist. Here's your 30-second recap.
Let's commit these first 10 minutes to memory. Minute 0, assess those ABCs and rule out the deadly mimics. Minute 5, get that 12-lead ECG done and attach the continuous monitor. Minute 8, secure your IV access, draw the troponins, and give that chewed aspirin. And by minute 10, apply oxygen only if their saturation is below 90%, give nitrates only when it's safe, and if it's a STEMI, make your reperfusion decision instantly.
I want to leave you with this final provocative thought to carry into your next ED shift. We've seen just how precise and evidence-based your first 10 minutes have to be. When the clock is literally ticking and you have a patient sweating, pale, and clutching their chest, are you ready to save a heart? Remember this. In MI, every minute matters. Recognize it, treat it, reperfuse it. Thanks for joining this explainer, and I'll catch you next time.